All right, welcome. Thank you so much for coming. I'm Natalie. I am one of the Geriatric Emergency Medicine Fellows at UC Davis, and I have my very wonderful friend and previous co-chief, Jacqueline Furbacher, who is a Health Equity Fellow at UMass. Today, we are going to go over defining food insecurity and malnutrition. We'll talk about some screening tools in the ED. We'll provide some strategies to address food insecurity and malnutrition in the emergency department and review some resources. We do not have any financial conflict of interest.
So food insecurity is defined by the USDA as a household-level economic and social condition of limited or uncertain access to adequate food. Essentially what this means is various factors like transportation access, the built environment, access to quality nutritious food, financial resources limit people's ability to have stable, adequate access to nutritious food. So there's a lot of worry around that, where are they going to get their food? It's on a spectrum all the way from hunger at the most severe form to not really being able to purchase the type of food you want. So having to go purchase fast food instead of being able to purchase fresh produce. In older adults in the US, the prevalence is around 8%. We do see a big variance across the country when we look by states. So the darker levels, the darker states are represented with higher rates of food insecurity. If you break it down by county, zip code, neighborhoods, you can see a lot of different varying rates. You also see varying rates in different demographic populations, so by racial and ethnic groups, Latinx, African Americans, and we also see in various healthcare settings higher rates of food insecurity, the emergency department being one of them. Food insecurity does predispose people to malnutrition, heart disease, diabetes, depression, and specifically with older adults, difficulty with activities of daily living and depending on others. It's also been associated with increased healthcare utilization and ED visits. Food insecurity also varies over time, so it may not be a fixed thing for people. When we look at our older adults, thinking about people on fixed incomes, you think about the beginning of the month maybe having more money than the end of the month, and then any kind of acute, unexpected financial emergency, an emergency department leading to a hospitalization, a stroke, any of those things that can make things even worse for people and limit their ability to access food. When we look at malnutrition, it's a lack of adequate calories, protein, or other nutrients needed for tissue maintenance and repair. Malnutrition occurs in about 15% of older adults in the US, and various factors contribute. So things like long-term effects of chronic disease and medications, physiologic changes of aging, and then also various social conditions, with food insecurity being one of them. About 25% of malnutrition in the US is a direct result of food insecurity. And it's been associated with increased mortality, susceptibility to infection, and decreased quality of life. In the emergency department specifically, the prevalence has been documented between 11 and 23%. And we see various rates based on if you're being admitted or discharged. So people who are admitted have higher rates of malnutrition, people with reported difficulty buying groceries, and reported difficulty eating, so things like having dentures poorly fitting or any trouble with swallowing, and then those with a history of depression. There are screening tools that are used, but often it's not consistently performed and not documented, and if it is documented, not used.
So we're just going to go over a quick case right now. We have a 78-year-old female who is a community-dwelling older adult without a history of cognitive impairment, who has a medical history of insulin-dependent diabetes as well as hypertension, and she lives independently on a fixed income. So it's the end of the month, and she's at the grocery store, and she can only afford one of these two options. So she can either buy whole nutritious food, but because she doesn't have enough insulin, just decrease her insulin dose. Or she can buy cheaper, less nutritious food like ramen and get a refill on the insulin and use the insulin correctly as prescribed. So I'll just poll the audience. Who wants to go with this option on the left? You gotta pick one. Okay. Ooh. Okay, like 5. Okay, and who wants to go with the one on the right? Okay, 4. Oh, 50-50. Okay. All right, so let's start with this one. So let's say that she gets good food for her, but because she can't afford insulin, she decreases her dosage. And a week later, her neighbor finds her obtunded and altered and calls EMS. And then she wakes up in the emergency department after being found to have a very high glucose level, and HHS is being treated, and she's subsequently admitted. So you can see the consequence of not having enough insulin and then just going high and requiring more healthcare utilization in that respect. And if we, sorry, wrong way, my bad. If we go to this option of getting an adequate insulin dosage, then again, her neighbor calls EMS because she is altered, and then she wakes up in the ED after having an episode of hypoglycemia because she wasn't eating enough but still using the insulin as prescribed. So you can see how these two scenarios can kind of lead to the same point as being in the emergency department due to some issue with food insecurity. So now we kind of talk about screening, and when we do screening for older adults in the emergency department, it's very important that we also have an intervention and don't do screens just to do them. So there's a paper by Molnar who kind of talked about how to do this process as it relates to food insecurity. And it's kind of like every other kind of QI project that you do. You need to implement the groundwork, do a good PDSA cycle, and I think the most important part is getting buy-in from your clinical staff or whoever's doing the screening so that they know that what they're doing actually matters and it's just not just another metric that they're clicking boxes on for that doesn't change anything. Then you test the feasibility with patients and you access your community partnerships. So there are 2 malnutrition screens and 1 food insecurity screen that I'll just go over very briefly. So the malnutrition screening tool is validated only for inpatient older adults. It's about 93% sensitive and specific for detecting malnutrition. You can see that it's a pretty short screen, so easy to use, however not validated in the emergency department setting. We also have the mini nutritional assessment form, which is the form that we use at my institution at UC Davis. It's a little bit longer, but it breaks people down to malnourished, at risk of malnutrition, or not malnourished. And in our institution, at least, we bring those results to the social worker who then connects them with resources. So this is for community dwelling older adults and only validated in the outpatient world. So again, not in the ED setting, unfortunately. And then we have the hunger vital sign, which was originally validated in the pediatric population in the emergency department, however, has not been validated for older adults in the emergency department. But this is an even easier screen because it's literally just 2 questions. So relatively easy to do.
So we're emergency physicians. We don't want to just learn about a problem. We want to fix it. So I think when we think about kind of what the standard of care right now is, it's really providing people just information about resources. But there's a lot of barriers for people to use those resources. When you think about older adults, you think about limited access to transportation, really difficult and cumbersome eligibility criteria. If you are non-English speaking, that adds another level of difficulty. And so in the literature, there's a number of healthcare-based interventions that have been done over the last 2 decades. Things like produce prescriptions, things like direct food provisions, and then connections with resources and referrals. Most of these are in ambulatory care settings, some hospital-based, but really not very many in the emergency department. When we think about what we can do in the emergency department, we have a very unique setting. We hopefully are only seeing people on a one-time basis. And so some of those things that have been studied in the literature really wouldn't make a lot of sense. But there are a lot of things happening in the community. And I think when we think about how we can really use our setting to really increase access to these resources, developing those partnerships and bridges and easing that referral process and doing more of a warm handoff can really be a beneficial way to get people access to the resources, because we see people that may not have access otherwise. So, there's community organizations that may help people navigate eligibility for SNAP and enrollment and things like that, or just even like a direct referral with they will then reach out to the patient. And building those partnerships can really help increase access without us having to really reinvent the wheel. Different resources available are SNAP, Meals on Wheels, food pantries, and things like that. The other thing to think about is looking at your hospital system and seeing what's happening there. A lot of hospital systems and healthcare systems are working on addressing food insecurity. So seeing if there are other things happening that we can either provide referrals for or really have a seat at the table with. For instance, like at UMass, we talked about helping enroll people for SNAP because we found out through the community partnerships and really understanding what's happening in the community that was a huge gap that we could fill. And instead of doing it in the emergency department, we're working on with the healthcare system to actually help enroll people for SNAP and trying to figure out how to do that. So there's a lot of things that we can do, and I think as we continue to learn more about this, and it's really about trying to be at a seat at the table and decrease the silos that we have in healthcare between healthcare systems and the community.
And I'll just echo what Jackie said. So pretty much this is the importance, right? This is what we're all trying to do. We're trying to have people utilize healthcare a lot less, and specifically the emergency department, increase their independence in ADLs. And I think this also goes to decreasing their risk of other things, such as falls, cognitive impairment, et cetera, which goes into improving the health outcomes and quality of life. So that is our last slide, and we're happy to take any questions. Yes.
Who does your survey? You said that UC Davis, you have that mini survey that's like 10 questions.
Right.
Is it the physician? Is it someone?
No, it's our Genie nurse, or I guess it used to be the Genie nurse, but right now.
It's the overall geriatric nurse, and we also
Okay.
have
Case managers.
Because that's like that's probably one of the biggest struggles that I see trying to implement this is, and nobody wants to do it, especially like nursing up front and triage. Like that just like, no matter, if it was life-threatening, they were like, we're not doing it anymore, just because
Okay.
of COVID and things like that.
Do you think the barrier is time, or what do you think is the barrier?
The barrier is, we have a suicide screen, we have a COVID screen,
Okay.
we have
Okay.
a domestic violence screen, like our nurses. And, it's just like, someone was trying to get HIV, universal HIV, all these things that are just not realistically, to do.
Okay.
And a number of questions, like I always thought it'd be a really great place to offload it to registration, but they don't want to ask, 12 questions, but you can get them to ask one. At least I'm working on trying to get them to one, like out of that mini hunger screen.
Mm-hmm.
And I can't figure out which is the better question to ask. The mini one was only 2
Yeah,
questions.
the
Because
hunger
it's kind
bites.
of the same coin but different sides of it. And
Probably the one with the high sensitivity, because it's not typically an emergency, so they can get a phone call from someone they can call back and just manipulate all these questions theoretically without having to overload like the question.
Right. And so that's at least how like, I'm trying to do it because it's a real challenge.
The other thing is like maybe moving it to the primary nurse, the bedside nurse, the primary nurse, but it gets done not at that intake, but at like 2 hours when they're doing their first and vital signs, when it's a little bit, the patient's a little more settled.
I think I'm at UMass as well, and we've done a number of social interventions, for lack of a better term, because you have a captive audience in the emergency department. And I think that that's pivotal as our, especially moves forward. That time that they're waiting for something, and they all do, right? How do we leverage that time? Because I worry about the follow-up. I think that will definitely capture some, but then, how are you going to get in contact with them? How are you going to ensure that they're going to go through with it? That face-to-face interaction has been huge for us in other measures, not this one. And how do you interface it? And I don't blame nursing. I mean, ED nursing is understaffed, as we know, and that's only going to get worse. And, they're worried about the problem in front of their face. This one, it's like hand hygiene. You can't see the benefits of your outcome necessarily right in front of your face. That's not a great analogy. But anyway, so how do you, because this one you do, I guess, if you capture a patient, I think that's rewarding. But anyway, how do you get it in that period of time within the ED, and how do we find the resources to do it?
Yeah, one other thing that we've been looking at is using community health workers, so actually adding another person to take on this. Because, like you said, we can't burden, we're all so, for lack of a better term, burned out from everything going on and adding another thing. And it's like, oh, do you have food insecurity? And that's not really the best way to talk about something so vulnerable. And so, community healthcare workers have been used in the ED for people with high utilization, as well as for just like helping people navigate primary care. So is there a role for somebody who's also like a member of their community and maybe has shared lived experiences, and then can they also follow up potentially afterwards? Or are there ways to like navigate that, and they then also are more integrated into the community and the resources? So I think that's a underutilized and maybe understudied area that has a lot of room for, because even just social work, like they have so many other responsibilities as well, that it's like you can't just keep adding on things to people, unfortunately. So yeah, no true solution, but I think if we can find other ways to really get that partnership with the community and use those resources, because in meeting the community in Worcester, I've noticed that a lot of people are really interested in working with the emergency department and want to do those partnerships. So it's like, how do we actually build that relationship and like find those ways to kind of link it together? So. All right, thank you guys.